So welcome to our first ever emergency department PA panel. So these are all professional PAs who practice in emergency departments in the area. We just kind of wanted to have them here to learn how practice kind of varies department to department and what their experience has been like. So we have a couple questions and then it's mostly going to be Q&A at the end. So I'll have you guys just introduce yourselves to start.
Hi, I'm Jan Kowalska. I work in emergency medicine, obviously. I work at the St. Anthony's Hospital System, and we cover a couple of facilities, various level 1 and level 3 trauma centers. The biggest one is 6th and Union. We've got a couple of 144th and I-25. We work in the mountains, so we cover a couple of different places. And I'm really excited to be here. Thanks.
I don't think I can top that. I'm Director of Reserve work at St. Joe's Emergency Department, employed by Kaiser, who's contracted to provide emergency services at St. Joe's, which is a SCL facility. And I'm mostly there, a couple of other sites scattered around. I've been there for 5 years.
My name is Jim Bauer. I work in the emergency department at Skyridge Hospital at Lone Tree. I'm employed by CarePoint Healthcare, which has a bunch of EDs all around the Denver Metro, but I only work at Skyridge. I've been doing EM for about 2.5 years. I was in Wisconsin at a small community hospital called Sheboygan Memorial until a few months ago.
Hi, sorry, my name is Robin Tyner. I work in the emergency room here at the university. I've been here for a little over 3 years. Prior to that, I did family medicine for a couple of years. Yeah.
So our first question is, what is your role as a PA in the ED you work in look like? So for examples, what kinds of cases are PAs utilized for? What is your scope of practice at your institution? Things like that.
So, do you want to go?
I don't care. I
You
can't.
start it. You got it. Who has a hand up?
So I think university is probably set up different than maybe many other EDs, but I don't think that we are actually utilizing the top of our scope by any means. We have a highly efficient ED in that there is a doctor who performs intake and triages and determines where people will go. And so we have a fast track area that is 100% solely staffed by the APT group, as well as an observation unit. So we do observation medicine. So some of those things would be, like cellulitis, admissions, or people who need a stress test, or we even have cards that round in the observation unit in the morning. But anything that we think that we could potentially get out the door in 24 hours or less to avoid a hospital admission, we'll go there. We staff that unit 24/7 as well. And then right now there are 4 main ED zones. We only work in one of them, and that does not have a resuscitation bay, so we currently do not have access to traumas or anything like that unless the other 2 areas where they do see those things are completely full, then we might get something there. We still do see sick patients with MIs and other sepsis or whatever, but just not really the trauma.
So Skyridge is set up such that in the mornings there's actually single doc coverage and then single PA comes on. And then as the day goes on, you end up with a few docs and a few PAs, and then things kind of taper off in the evenings. But frequently, you're there with a single physician who may be, and it's a 26-bed ED, so you can get pretty overwhelmed. The doc can get pretty overwhelmed. HCA, who owns the hospital and contracts with CarePoint, says that we can't see level 1 traumas, or there's this whole classification system, but we can't see very high-level traumas. And generally, patients with a systolic blood pressure sustained less than 90, PAs don't see. Outside of that, we see just about everything. That doesn't mean that we see that patient. Primarily, I pick somebody up, they're sicker than I think. This person needs pressors. This person has an arrhythmia, needs amiodarone because it's a critical GIP frequently. The doc will step in, but we pick up most folks without knowing how sick they may be. Sometimes that's really good, sometimes that's really scary. At my previous job, we had even more latitude. In Wisconsin, the supervision laws are actually a little bit less restrictive than they are here in terms of who's responsible for what. But we see most everything. I don't have a ton of experience, like I said, about 2.5 years, so I think maybe I'm on a tighter leash than some of the other PAs, but I feel like I have good latitude where I work.
I work in level 4 trauma trauma center that's also a stroke center. It's about a 45-bed department, and we primarily see undifferentiated patients, so I sort of see everything, and we're functionally, apart from trauma activations, we're essentially functionally indistinguishable from the attendings. There is a shift where we're sort of focused on lower acuity patients. That's a fast track area, but if that's not busy, you can float out. So we see basically everything, and you have as much help as you want. So you ask for help if you want help, and if you don't need the help, then it's not co-managed by a clinician. We do critical care. I admit, I transfer, I send OBS. I do most of the things that I would do normally independently. And a lot of the times it depends on which attending you're working with, because sometimes they'll say, hey, that guy's lactated baby, what are you doing with him? And I've been there long enough that I know most of my group, and they trust my judgment. And so every once in a while, somebody gets sick quickly, and then I ask for help. But most of the time, where I am, I function fairly independently.
I've been practicing for 15 years in emergency medicine, so I also, mostly with the same group, I should say close to 15. So I also have the luxury of being established within the system, knowing the providers. I'm lucky because when I started practicing, one of my biggest anxieties was, am I supposed to know this or not? Am I allowed to not know this? And moving along in practice, I'm like, I'm cool with not knowing this, and I'm okay asking for help, like being comfortable with like what you're expected to know and not to know. So that's just been something as you develop your practice, being okay with reaching out and asking the questions that you maybe initially are like, I don't know, is this a stupid question, or is this something I can ask more comfortably? I work at several different facilities. They're level 1 to level 3 trauma centers. Level 1's highest acuity, and so depending on where I'm working, you get a different sort of flavor of population. We usually, there's always physician coverage depending on the facility. There may be 1 or 2 or 3 other PAs and 1 or 2 or 3 other physicians as well as staffing. In general, the PAs, so actually our group now uses the term APPs, Advanced Practice Providers, and you heard from some of the panelists mentioning about a bunch of other acronyms like HCA and SCL, and as you move into medicine, you'll realize that there's all this medicine I'm going off on a tangent. You guys have never heard this. You'll realize that there's the medicine and there's the business of medicine, and the reason I'm getting this right now is I was trained in a certain skill set, and I have this thing that I'm comfortable with, and as I've gotten along in my practice, I'm more comfortable in sicker patients. But some of you may find this exciting. As a PA, the scope of your practice is shifting, especially in emergency medicine, because guess what? PAs cost less than doctors, and there's really a push to use PAs to the full scope of the practice. So, for example, in our group, we were acquired, given the opportunities to practice under a new umbrella of an organization called USACS, and they're really trying to save money, right? So. We're being encouraged to do intubations, to do air work, to do paracenteses, to manage much sicker patients. So my practice has really shifted, and I'm kind of getting out of my comfort zone of like, I know how to manage belly pains, I know how to manage PID, and I can do stroke. And I've been there longer, 2, our practice has shifted, so we're really seeing a lot of sicker patients. Stepping back, the PAs usually in our group, if you have like a stroke and an ankle sprain, the PAs take the ankle sprain, the physician takes the stroke. But when it gets busy, it's all hands on board. And then if you identify that the patient is sicker, probably going to be admitted, needs critical management, I will grab the doc and say, hey, I've got this patient sick, they're going to be admitted for something, they're hypotensive, I'm going to do this, you should just touch base with them as a general rule. So, but really, we're all sort of stepping up to the plate to manage kind of whatever comes in. You should start next. Next question.
Next one is, what, if anything, would you change about your role?
I wouldn't really change much of anything. In my shop, we have a pretty, once you've been there for a little bit, we have a pretty wide latitude of autonomy, and it's a very good mix of support and autonomy. There are times when I don't get enough support. Like sometimes I have putting in a central line, and I say, just go tell the attending I'm putting a central line in the sick patient, and they'll walk by and pull the curtain back and go, "You got it?" I'm like, "Yeah." Okay. And they walk off. So sometimes I need more help than I'm offered, so you have to know when to ask for help and what to ask for. But we also do we only call ortho when we're going to send somebody to the OR. We do all of our reductions. We do everything ortho. We do not call plastic surgery. We are the ones who do all the complex laceration repairs. We do flap advancements. We do lots and lots of stuff. And so there's a lot of times where the attending says, "Yeah, this guy has a disc where he's fractured. You need to go see him." So we do a bunch of stuff that they won't do. So the only things that I would change about my practice are not problems with my practice, they're problems with medicine in this country.
And we all probably echo that, that there's a lot of structural problems with medicine right now related to billing and what do we do and what don't we do in departments. But I wish that I could fast forward to about a year from now. So I worked 2 years in my previous location. I developed great relationships with my docs and consultants. It was a small hospital. I would call neurology and say, "Hey, Steve, I got somebody with a neurology problem." And we knew each other. We knew each other's comfortability level. And now, having just moved to this new job, I don't really have that. I work with many more physicians. There's many more consultants. Sometimes Dr. Barkin, for example, wants this done and not that done. And Dr. Talbot would never want that done. And if I did that, he would get kind of angry. And being that I'm new, I don't have as much autonomy to say, this is how I would like to do things. My practice is under a little bit more scrutiny, I suppose. And where I was before, we had a lot of trust and a lot of latitude. And as I said before, I do get a lot of freedom, but I'm looking forward to when I'm much more comfortable and they're more comfortable with me, and maybe we can start making things a little more efficient. But I like Skyward. I think it's a good facility, and I like EM and the PA's role in EM. I don't want to do it for a cotton. I have no interest in like these high-level trauma resuscitation procedures. Some people do like to do this. I don't know. That's just me. But I do feel like the scope of EM practice for me and for the PA.
I think, just as I alluded to before, the only thing that I would change, which we are making progress with that, would be for us to move into the resuscitation phase. So I still feel as though we see very sick patients anyway, and I'm comfortable with that, and I feel like I've had the opportunity to build relationships with the providers that I work with, which is nice. But other than that, I don't know that there's anything else that I would really change. I think I love the people that I work with, which is really important, and that's about it.
So last question that I have is advice you would give to future EDPAs about skills or areas of knowledge to improve before applying to an ED position.
You have to do an EM rotation. Outside of that, I did cardiology. I didn't do an ortho rotation, and I think that probably would have been useful. I think getting a sense from your rotations, because that's really where you're gonna learn, of what does the rest of the system look like? What are the real complexities in cardiology? What are the real complexities in orthopedics? What's going to happen to that patient with a trimalleolar fracture when you send them to orthopedics? And what's important for you to know about what you should do for that patient before you send them? I think just developing sort of a broader appreciation of how the rest of the system works is important. I don't know if doing any one thing in particular in rotations is going to make you more attractive to employers than anything else, but just being aggressive, getting in as many procedures and those sorts of things as a student as you can, and recognizing that there's so much to learn and that you're going to have to work really, really hard, especially in the early times, to get your skill set and get comfortable.
I think surgery is one of the most important things that you can get familiar with if you're going to go into acute care medicine or emergency medicine or critical care or TACS, trauma acute care surgery. So much of what we do is surgical disease. Knowing what happens from here is critical. I was a paramedic for 13 years before I was a PA. And part of the reason I am not a paramedic anymore is I would drop the patient off and then just sit there and wonder what happened. And so as a student and as a new clinician, what you should be thinking about and wondering is, I have this patient, here's what I'm going to do, and I'm going to get things started, but what you need to know is what happens next. Like, where does this patient go from here? Is this pulseless foot going to go to the operating room tonight, tomorrow, never? Are they going to get a stent? Are they going to get a bypass? So it's one thing to say, oh crap, this leg pain is, they don't have a pulse in their foot, and it's purple. So, but next you have to say, okay, well, what happens next? Do they get TPA? Do they get catheter-directed thrombolysis? Who do I call? Do I call ortho? Do I call vascular surgery? What happens? So when you're doing a rotation, if you're doing a rotation in acute care medicine, those are the questions that you should at least have for you, but you should really have it for whoever you're working with, is to say, what happens now? I mean, you admit somebody with pneumonia, what do they do? And the best way to learn that once you're in practice, or supposing when you're a student, is follow up on your patients. I mean, I've been out for 12 years, and I still, whenever I admit somebody that is sick or I'm not sure if I had the right diagnosis or maybe I had the wrong diagnosis that I realized right when I admitted them, I follow them out and I go, oh my God, they just had nothing, or they sent them home, or why would they send that person home? Like I called a vascular surgeon in the middle of the night for a guy with no pulse in his foot, and they say, yeah, just give him some heparin later tomorrow afternoon. But I always thought this is a limb-threatening emergency. They're like, no, if they're not paralyzed, it's a 2A ischemia, and we'll just revascularize them in the afternoon after clinic. Why did I call you at 3 in the morning? So you be curious, and don't just deal with what's in front of you. Pay more attention to the longitude and what's going to happen after I take care of this patient. Did anybody answer the question?
No, but I'm going to do that for you. So the rotations you should take.
Oh, surgery.
Surgery. I'll agree with that. When you don't spend 12 years, how many years as a paramedic? 12 years as a paramedic, I found it helpful to do cardiology because you do a lot of cards. I tell people to do ortho because you will become the default eyeball specialist since they're always just level 4s. And these patients who have eye issues, the doctors never take them because they're not like sick enough, not like a high acuity sickness. But imagine losing your eye or losing vision. That would be very sad for the rest of your life. So you will become the ophtho specialist. So if you have the option to do that, do some of that. I tell people a 2-week rotation. I don't know if you guys have the option to do a 2-week rotation or if they'll take you for it. Ortho is a great thing because we do a lot of orthopedics. Those are the ones I thought were the most helpful. That's a good question.
Well done.
Yeah, I think everybody answered those questions really well. I don't know that I have a whole lot more to add. I think ortho is super important. We actually consult quite a bit where I work on ortho just because we have a residency there. We don't do a lot. I have reduced shoulders, but we don't do a lot of reductions. Also, if you have the opportunity to do like maybe an urgent care rotation, I think that would potentially be helpful. And just knowing that it's really difficult as a brand new grad to get into emergency medicine anyway, don't be discouraged by that. There's plenty of other things that you could do ortho for a year, or you could do urgent care for a year or something else. I did family medicine, and I thought that helped me. Still, I did minor procedures and stuff in family medicine, so don't be discouraged by that.
So now we just kind of have time for open Q&A, kind of ask whatever you feel. And then if you guys could just repeat the question so that people watching later can hear it.
Your computer went to sleep. Is it still recording?
I don't know.
Can I say something else? I have no shortage of words. I think that the skills labs that are out there are really helpful. Those academies, there's like a couple things out there, and I've mentioned in class, but there's crash courses in emergency medicine. Just get a ton of procedures. I think those are boot camps. Yeah, the EMIG boot camp. We've had a couple of our new grads go through those, and they've had really positive reviews on them. So I think that would be something to consider. I know there's a lot more opportunity to get into EM residencies, and I think people can maybe comment on those, what they feel about that. And so that's an option for you. When I finished up, it wasn't really an option. You got into your job and you started working. And as an aside, I think the expectations of people getting into emergency medicine are much higher now than they were 10 years ago. I think there was a willingness to accept a new grad and the need to learn skills. And right now, it's kind of like, well, if we can't figure it out, this isn't going to work for us. So you kind of have to come in hitting the ground running. So that an emergency medicine residency may be a way to do it. Another way to do it are these boot camps. I think they're very helpful. Yes.
I was just going to ask about the boot camps. Is that something that you do? These are some things like after graduation. I've never heard of this.
Yeah.
Can you explain those a little
Yeah,
bit?
so there's one, I think it's called EM boot camp, and it's down in like in Vegas and something.
Yeah.
So you can actually speak
Yep.
to it here.
Mhm.
Here, why don't you? Do tell.
So I went to EM boot camp about 6 months after starting my job at ED in Las Vegas. It was a lot of fun. There was a lot we got out of it. A lot of like the big ED luminaries talked there. One of the guys from MRAP talked. MRAP is a really good emergency medicine podcast that I listen to some frequency on. But yeah, I mean, they do some skills labs. I don't think they did it in mine, but I know that's available. But just
You can pay extra. They have like a separate skills lab. Yeah.
Sure.
Yeah.
But there's a lot of these very well boiled down. Here's something that you really need to know. Here's something that you probably didn't know that will be very important and help you managing the super common diagnoses like chest pain, back pain, belly pain. Like if you back pain, for example, needs to be just an absolutely automatic thing. You know exactly what you're going to do. The exam you're going to do. What are you looking for? And boot camp helped me sort of solidify that in a way that made me a lot quicker and I think more efficient. So I don't know. I recommend it. I didn't do it as like a student in PA school. I don't know if that would be helpful or not.
When you're done,
Yeah.
when you graduate, it's
Yeah.
time to do it.
I don't have anything to add. So.
If you can, and I think the student membership is reasonably affordable, the EMRAP, Emergency Medicine Reviews and Perspectives, is a podcast, and most of my partners listen to it. It's how I get all my Category 1, and it's really well done. It's out of UCSD. It's got a lot of regular speakers that are in sort of nationwide, like I'm on to. And it's not, some of the podcasts are like college lectures you had where people say, if you'll look at the screen, you'll see this reaction between carbon and it's good to fall asleep to. But MRAP is very, like
No,
it's
it was too close.
there's like a lot of sound engineering, a lot of production that goes into it, and it's actually pretty entertaining. There are some segments that I feel like maybe they get a little bit into the weeds. It's literature-based, it's current. There are a bunch of segments where it kind of falls into a learn it today, use it tomorrow thing. I've had many times where I've listened to this month's episode, and on my next shift I go, oh, yeah. And I just heard this last night, and I'm like, oh, this is great. So it's valuable, it's entertaining, it's Category 1, and it's, I think, the PA rate's like $250 a year. So, EMRAP, and there's a ton of stuff, like how do I reduce a shoulder? They've got HD, they've got videos, like how do I repair a nail head and finger laceration, how do I repair centesis head and thoracentesis? I mean, you can just get lost on this website for the whole weekend if you're into that kind of.
I was going to ask, what is your opinion about the ED residencies versus versus going into a more more wide focused practice like family medicine or family practice if your goal is to get into the emergency room?
So the question is, what's the value of doing an ED residency versus doing something more general practice if your goal is to go to emergency medicine? As someone who's done quite a bit of hiring, both here before I was at Kaiser and now, an emergency medicine residency is helpful. It doesn't guarantee your job, but it's definitely something as someone who does hiring, it is definitely helpful. It's better than doing ophthalmology for a year. Remember that about half of PAs will have a different job 2 years after they graduate. You do not have to pick the right job the first time. It might not be the right fit. It might not be the right specialty. It might not be the right group. I did cardiothoracic surgery straight out of school. And most of the cardiac surgeons I work with, I'm not sure I'd put them out if they were on fire. But the thoracic surgeon I worked with was amazing. The guy was awesome. I mean, this is somebody you're going to be standing head to head with for 3 hours. An amazing guy. Go mountain biking with him. It was the right group, the right practice, the right specialty for me. But don't feel this self-imposed pressure that you have to pick the right job first out, because it might not be, and that's okay.
The residencies, Marquette, where I went to PA school, offers one, and it's my understanding that it's a pretty big deal. The people that graduate from it seem to know what they're doing. I applied and got in, and then there was no other interest that year, and so they just said, well, we can't do residency for one person, so sorry. And things actually worked out okay for me. But I think the residency is really helpful, and the market is tough. So getting something like that under your belt would be good.
Hey Jim, can you just tell a little bit about Adam's experience in residency and like what you do and where you rotate to?
Sure. So one of my good friends, Adam, who I went to school with, did the ED residency a year after me. It's split up into several blocks. You spend time in a variety of different emergency departments. It's in Milwaukee, Wisconsin, so there's sort of these inner city, quote unquote, very underserved sorts of EDs where you do medicine that's very different than what I do. For example, it's Kyridge in Lone Tree, certainly a very different population. You also rotate with orthopedics for several weeks, anesthesia for several weeks. You just intubate people and intubate people and intubate people and get super comfortable with that. They try to do you a lot of procedures, a lot of LPs and these sorts of things, and they give you a broad base and a broad focus. And they also have you do lower acuity stuff. They found in previous iterations of the residency that you would do so much higher level clinical medicine that you would have a sore throat or something like that and say, I'm not, this person's not that sick, I'm not sure what to do. And so they sort of give you this broad reach, but you do make a lot less money for a year. You work sort of at bad shifts and bad hours, and I think a lot of the things that many of us really like about emergency medicine, you definitely don't get in the first year. But if it's a good job, that's nice too.
With respect to the residencies, I think a lot of it depends on how comfortable you feel. Also, we've had a couple guys, and actually, one woman, some people who have come into our group who have been fantastically prepared for it. They just have had a great background, and a lot of them are paramedics, so they're comfortable with really critical patients, and just they're super smart EPNs, so they retain everything that they get exposed to in PA school when they come in and they hit the ground running right off the bat. And if you're that type of person who's like, I'm comfortable, I know what I learned, I'm comfortable with what I saw, I'm a C1, D1, teach one kind of person, you got it, then you may not need that. But if suddenly you find yourself like, oh my gosh, I'm going to kill someone, like it doesn't matter what patient it is, if you really have a lot of anxieties about that, it's nice to have, I think, somebody else hold your hand for a little bit longer. So that would be kind of my take on it, is a little bit the self-reflection of who am I, would I like a little bit of extra help, because I think they really do provide it.
Going off of that, so if you're not in, like a residency or something, and someone's not like holding your hand, but you do like want to learn something new, or like want to try to innovate, or like something like that, in your experience, how easy is that like on the job to learn those
I
things?
would encourage you to seek out a job that has lots of new grads or has a program set up. And CarePoint has got the CarePoint, right?
Yeah.
So they've got, you can talk to this, but you can speak to this, but TAD runs a new grad training academy. Our group is terrible with new grads. We've had people leave crying. It's awful. We're just not set up to help people, and it's something we've really struggled with, like how to create that space for it, because you need it. You need a place to learn. So I worked for several years in a teaching hospital. I stayed at Yale New Haven Hospital. I worked in a busy inner-city ED where there's layers and layers of checks and balances and people around, and it's set up as a teaching program. So if you want to do that, I would encourage you to find a job, go somewhere, be in an inner-city hospital, work the night shift, work run shifts, and just make sure you have lots of layers of help. There's jobs out there. Look for those types of jobs. Let's say, new grads welcome.
That is something that I would say. TAD does run a new grad academy. I did not do that because I was not hired as a new grad, and there's not a lot else in terms of onboarding. I shadowed for a couple of shifts, and then it was just kind of go ahead, go do what you want. I would say that in a non-teaching setting, I would totally echo that there's very little opportunity to learn new skills. We're super busy. We're always busy. The docs are always overwhelmed, and so are we. We have trouble getting in just to do a joint reduction frequently, like to do a conscious sedation and reduce so that me and the doc in there. The stars have to align in a way that sometimes that patient sits there for quite a while. And so for me to say, hey, listen, I'd like to put the central line, I'd like to intubate somebody, I'd like to do a lumbar puncture, and I need you there with me, that does not happen very frequently. That's one of the big gaps in my practice that at this job and wherever I'm next, I would really like to address. But frequently, it's a function of how many people are there and how much time you have. And in my job, both of those are very low.
Yeah, that's part of the reason it's difficult to get a job as a new grad or a recent grad in emergency medicine. Is it depends on where you are, but there's always an element of you got to move the meat. You got to see patients. You can't see, a patient every 90 minutes. You can't really see a patient an hour. It's just that's not why you're there. That's not why you're hired. That being said, if you end up in a practice where there is some teaching, be the annoying kindergartner. Somebody's like doing a sedation for a reduction or they're doing something cool. Go to the room and say, hey, what are you guys doing? And that's how you learn a lot of stuff, is just kind of be annoying, don't be shy. And it's hard, right? Because you learn enough in PA school to not kill people. And so then you have to learn how to actually practice medicine. And if you get 2 hours of orientation, you're like, all right, let me know if you have questions. Head out into the fire, and you're like, oh my God. And so it's hard to learn when you don't know what you don't know. And so that's the hard part about EM as a new grad is there's so much that you're responsible for. There's some things that quite frankly seem like a nuance now that are really important. And if you don't have someone guiding you through that, and you don't have good preparation going into it, you're going to be crying or something. But it's a hard environment.
Awesome.
Still interested?
Yeah, sure.
I agree with that. And one other thing to keep in mind too is that they call it practicing medicine for a reason. I mean, literally, there are times things come in and you don't have anybody else to help you. And so I remember the first time I had to do an arthrocentesis on an elbow. I didn't have anybody to show me. It was like, look it up and do it. And so I looked it up and I did it. And thankfully, I got it. But you just got to be comfortable. I mean, really, sometimes that's what happens. And if you can't get it, then you're going to be able to get somebody else to come in and do it. So, don't be afraid to try something.
So, what do you like about emergency medicine? what initially drew you to it?
Those are 2 separate answers. What I like about emergency medicine is that you have a moment, you have this really, really concrete, brief time where you can do something really good for somebody. Those are the cases where I'm able to do that are the cases that make me want to go to work the next day. Not all cases are like that. Maybe not even most cases are like that. But every once in a while you get somebody where you intervene in a meaningful way and they feel better, something happens, they get what they need. Maybe they didn't need anything and you just tell them that and they feel better. It depends. I think the lifestyle is fantastic. I took off 15 skiing days so far this season. I have a lot of unstructured free time to do all kinds of projects and fun things that other people just don't get to do, which I like a lot. But certainly there's trade-offs there, but okay.
It's as far as areas of practice that you can do as a PA, it is definitely has the most autonomy, and with great power comes great responsibility. So it has some of the highest exposure, both medical legal and just general practice of medicine risk. And so I think a lot of it has to do with your personality and what you're comfortable with. Are you a low risk, comfortable person and you don't want to make very important decisions with very limited, potentially inaccurate information? Or does that do something for you. And if that does something for you, then emergency medicine is for you. You're going to work nights and weekends and be exposed to some kind of terrible stuff. But the trade-off is you get to see some very interesting and wild things where you no longer will say, you put what where? Oh, all right, fine. You don't really get surprised by much anymore because as soon as you're like, wow, I don't think I've ever heard that before, you hear something that you've never heard before. And you're probably all too young to remember Frogger. The video game Frogger. Well, I mean, yeah, there's some, there. Hopefully we're talking about the same thing. And that's kind of how I think emergency medicine is. So this is the game where you have to cross the road, you're a little frog, you got to cross the road, get hit by a car, and then you're on turtle sings, alligator tries to eat you. That's kind of what emergency medicine is. Some of the patients you see are going to be sick, and you won't necessarily know that straight away. And it was actually put to me very well by one of the critical care fellows I work with in surgery. 80% of what you do doesn't matter because the patient's going to be fine despite your efforts. But 20% of what you do really does matter. The problem is we don't really know very well what is in that 20%. So you have to be okay with uncertainty.
What I like now is what I hated at the beginning. Essentially what I'm trying to say is there's so much material that you have to be familiar with. I would offer master, but that really starts to stretch because you never really master anything. You gain a familiarity, you gain comfort with what you know and what you don't know. And sometimes after a busy shift, so there are just busy shifts where you just figure stuff out and you get interesting presentations, you put things together, you feel smart, you look things up, and you talk to your consultants. And I'm like, it's really cool that I have this, I go to this job and I have no idea what's coming in. It's my job to be a detective and put it all together and be nice about it and do it fast. So I mean, but it's really, this is cliche, but it's kind of an honor to have that opportunity, right? So you're not just going to deliver Starbucks and your biggest screw up is decaf on the patient wants fully loaded coffee. So it's interesting. So that's a lot of what I like about it. It's very interesting. And you keep learning. You have to keep learning. You don't have the luxury of being like, thank God I know all of this subspecialty now. It's like every day I'm like, well, which topic do I need to continue learning about? Or what factoid did I know about 10 years ago and then I've long since forgotten and I have to go back and find that again and relearn it? Because you keep learning. And it's interesting, it's frustrating. It gets annoying sometimes when you're like, I should go skiing, but you're like, I should also learn about this. Or, I like the detectiveness of it. And that was, so what I said is it was very hard at first, because when I started, I'm like, I can't possibly be expected to know a little bit about everything, but you kind of have to right off the bat. And then when you practice well, you get it figured out. I like the schedule too, I love it. I don't mind working holidays, although as my kids are getting older, it makes me a little bit sadder. But it's great to be like, I'm going to go work on this holiday, and I have Tuesday, Wednesday, Thursday off. And I'll do, like, all you people are going to go to the grocery store and, with everybody else, or you're going to go to the ski hill with everybody else. I'm going to go when there's nobody else out there. So it's nice to have that flexibility. And honestly, you could build in a 2-week vacation every 2 months. Because you take the last week of 1 month off, the first week of the next month off, and you could have an amazing, you could tour the world. So this gets great, except for nights.
Yeah, in a lot of jobs you can never do that. Like in my surgery practice, it was 60 hours a week, and Monday through Friday, and I had a call a week and a weekend call a month, and I did nothing but sleep and work. But it is really amazing because you get to a point. Some of this happens earlier in your career, but I think it also happens much more later on, where you know things and you don't even know how you know them. In emergency medicine, you have to know a little about a lot. There are some specialties, like if you do room, you know a lot about a little. And you know room, you get it down. But if somebody comes in with like an eye problem, they're like, that's not room. But in emergency medicine, you have to kind of know it all. Somebody comes in and says, I have sarcoidosis and sickle cell anemia, and I have Crest syndrome. You can't go, is that a toothpaste? Crest syndrome? So you kind of have to know at least a little bit about, I know that is some kind of autoimmune rheumatological type thing, but you'll get to the point where somebody will say, like it's weird because I ate at Red Lobster and now I get a hot shower and it feels cold. And you'll go, oh, that's secretary poisoning. And you'll go, how did I even know that? And you'll just accumulate this knowledge through practice. And it's just really amazing the way your brain will sort of assimilate all this and you'll process it. And somebody will give you this information and you'll say, you're not sick, there's nothing wrong with you, you go home. And that's the hardest part in emergency medicine is doing nothing. Because depending on what kind of center you're in, like Robin has everything. You could MRI somebody's earlobe in an hour. The hard part is knowing when you don't have to do anything. Sending somebody home, that is where you're in flight pay. That's the scary part of emergency medicine. If somebody comes in chest pain and you need EKG and you go, it's okay, story is not concerning, we don't need to do anything else, I'm sending you home. And then you stare at the ceiling for 2 hours before you go to sleep. But because you can't test everyone for everything. You can't send a strap on everybody, you can't send influenza on everybody, you can't get everybody with belly pain does not need to be CAT scanned. That's the hard part, is knowing who doesn't look that sick, who doesn't have an impressive belly exam, and who doesn't need to be scanned. And that's where your accumulation of knowledge in your clinical practice gets developed.
I want to say one more thing, because Brent didn't answer the question again. The other thing I like about the job is
That's what I was just
accumulation
talking
of
about.
knowledge. So this is a funny thing. I never would have sought this out in a job. I love the fact that I'm mobile all day. Could you imagine going and sitting at a desk for 12 hours?
Yeah.
Like, you are literally running. You gain physical fitness by working in emergency medicine. You don't have to go to the gym. You go home. You go to bed. I actually really like that.
Yeah.
Like, I couldn't make it through a 12 to 14 to 16-hour shift otherwise, but you are literally moving all the time, and there's no time to be like sleepy because you got to keep going. So that's one of the things I like about the job.
All right, can I answer the question? So I'm admittedly a little bit, pretty much everybody in emergency medicine at least has a little bit of ADHD, but that's what makes us function. And I like being able to say, is there a problem, yes or no? Are you sick, yes or no? Is there something I can fix, yes or no? No, okay, I'm moving on. And there's not a lot of other places where you can do that. A lot of times you have to sit down. I mean, I listen to my internal medicine colleagues and hospitalists sitting down and like doing the entire stem to stern history and family pedigree and did your grandmother ever have toenail problems or whatever. And I just, oh man, that makes my right eye twitch because that's just not me. Is there a problem? Can I fix it? Yes or no? Can I go home? Do they need to be admitted? Do I need to do this? Yes, no, get it done, and then move on to the next person. If that sounds terrible to you, then emergency medicine probably won't work out. But if you're the kind of person who says, hey, that sounds terrifying, and when do I start? Then you should do emergency medicine. And that's what I like about emergency medicine.
And I would say that I don't appreciate that every day. I don't know if I could sit around and ask people about their grandmother's toenail fungus. Like, I don't know if that's something that I could do in my practice and be fulfilled. But sometimes I do want a little bit more. I don't know if I'm going to do that forever. Sometimes thinking about rumor. One of my friends from PA school does pediatric epilepsy. That's it. It's all pediatric epilepsy all day, and she knows everything about pediatric epilepsy probably. That might also be cool. But yeah, there is. I don't love the job every day. I'm not gonna say that this
Nobody
is
loves
a
job every day.
fantastic
You don't
job.
love the job every day.
And sometimes it's really, really awful. And sometimes I lay awake in bed for much longer than 2 hours thinking about somebody, and that is something that you have to take on and know that that's part of the game. But you do the right thing. You try to do the right thing. You do the right thing with the information you have, and usually things go okay. You didn't get my fun shape you like about emergency medicine.
I think you guys have covered it all. I really just, I mean, as you said, I like the unpredictability of it. That you come in and you never know what's going to come up, and that you do get to see a wide variety of things. And I do like the fact that you're active every day and you're up running around, definitely. But you know, to his point, there are days that are hard. There are things that you see for patients that, I mean, I don't know. It's like if every nice person gets cancer. I mean, really, you know, and those are things that are hard and you do take home with you. but the schedule is very, very nice. And you're not going to ever know anything, ever know everything about it. I think there are specialties that you could get into where, if comfort is what you're looking for, maybe emergency medicine isn't for you. I mean, you will develop a certain degree of comfort regardless. I mean, when you come in, you're terrified and you feel like you know nothing. And you're asking a million questions, and then you get to the sweet spot where it's like, well, I know this person's not sick, I can't send them home, but there's always going to be things that you don't know about, and you're going to have to know when to ask for help. So
Maybe we can do just kind of like one sort of small question for the remaining time.
Yeah, I know that you're a preceptor. I don't know if anyone else is. But could you talk a little bit about like EM rotations, like how much students are able to do, what we can, like if we want to do a lot of procedures or like at least like learn to do procedures, how can we optimize that experience?
The question is what's kind of scope of practice as a student in emergency medicine and what has to do to optimize the experience? Yeah, I'm not a preceptor.
Be curious and ask to do stuff. I had students and preceptees who just kind of sit there waiting for direction. That ain't gonna work. One of my EM rotations, I was essentially running resuscitation for a dissection, and I was putting in an art line. And a couple of nurses were like, "Why is the PE student being an art line?" So if you say, "Hey, I want to see that," or "I want to do that," or "Can I," again, be sort of the annoying kid, and say, "Can I do this?" Or say, "Hey, I've never seen one of these," and I actually went around to some of the attendings that I got to know at my site, and I said, "If you guys have anything cool, please come find me." Absolutely do that. You got to be curious and inquisitive and interested. If you're just sitting there waiting for diffusion to happen, for you to get information, they're going to put you in the corner and make you watch a video.
Basically that, just be aggressive. Not aggressive,
That's
just
right.
sort of sorry, yeah. Just ask. I want to see this, get up, I want to see that patient. Just get up and do stuff.
Awesome. Can we give our audience a round of applause? Thank you so much.